Hello, everyone, and welcome to session 3 of 3D Diagnostics series of educational webinars. Allow me to introduce myself. My name is Dr. Abbasy. Many of you know me as Dr. Epps from 3DX. I went to dental school in Cairo, Egypt, and finished my Master's of Implantology in 2015 from Goethe University, Frankfurt, Germany. I've been placing implants since 2011, and I've been working in 3DX since 2014. And today, I can proudly say that we are a team of more than 25 3DX doctors to help you achieve the ideal treatment plan for your implant cases. First of all, I would like to thank each and everyone attending today, and please feel free to add any question in the Q&A box, and it will be answered either by one of the panelists during the session or by myself at the end of the presentation. So today's topic is the pitfalls of guided surgery and how to predict, foresee, and overcome any challenge or pitfall that you may encounter in your next guided implant surgery. Before starting, let me share with you a significant personal experience. It's not an implant dentistry, to be honest, but it was while I was scuba diving. Anyone here scuba dives? If yes, please let me know in the chat box. And let me share a different screen. Hold on. Now you should be seeing a video now. This was one of my first close-up shark encounters. It's in the Red Sea, one of the things that keeps us sane living in Cairo, the beautiful Red Sea. This was off the coast of Marsa Alam in the deep south of the Red Sea. And this guy was more than 6 feet long, and he's an oceanic white-tip shark. And these geniuses swimming with the shark are pilot fish. They have what is called as a mutualist relationship, where they feed off parasites of the shark's body, and in return, nobody dares to feed on them. So this was a bit of a curious shark, and at this moment, this shark decided to tap my shoulder, or my dive buddy's shoulder, 3 times. And at this moment, we all wet our wetsuits, to be honest. And then chaos occurred, and we had to end the dive because the shark was getting more and more aggressive. The question is, what do you think we did after this dive? The first thing that we did. Hold on, let me go back to my screen. You got it right. The first thing that we did is we changed our wetsuits. But then what we did is we signed up for shark diving courses and workshops. And we realized the amount of blunders we have made that might have caused major damage. And my friend is a dentist as well. So if this big guy took a bite off his shoulder, I mean, it could have been a catastrophe. Now, the point I'm trying to make is that education is power. Education is key. And I hope that today's session will help us find a vantage point to foresee and avoid potential pitfalls in your practices. Now, before discussing the pitfalls, let's go through some advantages briefly. Flapless surgeries with guided surgery are no longer a blind procedure, but gives you very predictable results. Implants are planned and placed prosthetically driven, not following bone, irrespective of the final prosthesis position. Guided surgery made placing implants in tight and challenging sites now possible and much more predictable. Visualizing implant positions in relation to vital structures. For example, planning implants to stop your drill at the cortic lining of the sinus for you to proceed with a sinus bump or internal sinus elevation. And of course, planning implants safe away from anatomical and vital structures like the lingual concavity, it's where the lingual nerve and the lingual artery runs. Guided surgery today allows us to prefabricate CAD/CAM custom-made abutments and restorations, enabling immediate loading from single units and the onesies and twosies, all the way to the full arch restorations. Now, it's very important to acknowledge that a successful guided implant surgery starts as soon as the patient walks into your office, starting from the CBCT, patient evaluation, taking impressions, the distal workflow, pre-surgical preparation, all the way to the surgical and post-operative evaluation. So, the CBCT. Let's go over some of the guidelines and talk about its significance later in this presentation. Using a slice thickness of 0.4, 0.5 millimeters. Now, the smaller the slice thickness, the higher the resolution. The smaller the voxel and the higher the resolution. So having a small slice thickness is important for accurate treatment planning. Make sure the patient doesn't move, because when the patient moves, we get what is called as motion artifacts in the scans. The occlusal surface of the arch of interest has to be horizontal. This makes the orientation in the treatment planning software easier to adjust. The field of view must cover the arch of interest and 5 millimeters of the opposing arch, which means quadrant scans are not ideal, and we will know why in a couple of seconds. Teeth separation is also very important, and again, we will know later in the presentation. Lips and cheeks separation by placing cotton rolls in vestibules helps a lot with the distal work in treatment planning and surgical guide design. Step number 2, impression or intraoral scan. Now, a question that is asked a lot, which is better, PVS impressions or intraoral scans? Well, I would say that a good PVS impression works fine for surgical guide design, but it is worth mentioning, though, that literature states that distal impressions and intraoral scans are definitely more accurate than conventional impressions. Another important question is, does alginate work? Well, it may sometimes work, and it may have worked for a couple of your cases, but the question is it really worth risking the accuracy of the surgical guide and the surgical guide seating and the accuracy of the implant position? Or let me ask you another question. If the alginate impression was very distorted, is it worth getting in the patient again for a new impression? We do know how frustrated or the frustration patients feel when we get them in again for a new impression. And that is why we always recommend a PVS impression or intraoral scan, and more importantly, always check the impression yourself before you send it out and make sure it's a good full arch impression with adequate distal extension before dismissing the patient, so that you still have a chance to take a new impression if needed. It also goes without saying that if the impression is poured, then it should be clear of any air bubbles or voids. And if you do ship your physical models to 3DX or a distal lab, make sure to bubble wrap the stole model before you send it out to avoid any fractures in the stole model. Also, the impression must always represent the patient's dentition at the day of surgery. So if you're planning any restorative or crown work, then it should be done before taking impressions. Moreover, it's recommended to shorten the duration between the day of taking the scans, both CBCT and intraoral scans or impressions, and the day of surgery. Since, as we know, teeth tend to move or tilt if there's a missing tooth and if there's space available. So try to always shorten the interval or the duration between the CT scan and taking impressions and the day of surgery. STL registration on the CT scan. Now, what is STL registration? This step has been explained in session 1 by Dr. Todd Engel, and in session 2 by one of my dear friends and colleagues, Dr. Shadi Hassan. And I will go over it because of how crucial this step is. Now, for any TOOS supported guide, 2 files are needed. The DICOM files, which is the patient's CBCT, which is used for planning the implant. And the second scan is an STL file, which is the patient's impression or intraoral scan. And that is where the surgical guide is actually designed on, the STL. Now, these 2 files are merged together by what is called the STL registration. Now, what we see here is an occlusal view of a 3D segmentation of the arch of interest from the CBCT. So this is a segmentation from the patient's DICOMs, from the patient's CT scan. And the other scan is the STL, or impression, imported in the software. Now, the same reference points, let it be cusp tips or incisal edges, are chosen on both scans. And then the software automatically merges both scans according to the reference points that we chose. In some cases, some manual adjustments are required. Now, these images on the right shows the STL registered on the CT scan. So this yellowish green line represents the STL registered on the CT scan. And in this 3D view, we can see the intraoral scan accurately registered on the 3D segmentation of the CT scan. So if any inaccuracies occur in this step, keep in mind that the guide will seat in the patient's mouth, but the implant will end up in a different position from the pre-planned position. And this is why it's a very, very crucial step. Now, be assured that if this step is clear and makes good sense now, then the following pitfalls can easily be avoided. CBCT scan evaluation. Now, after taking any scan for a surgical guide and before dismissing the patient, I would always recommend to analyze or assess the following. Number 1 is teeth separation. Now, what do you think is the main problem here? Let me go back a slide. With no teeth separation, it is almost always very difficult to obtain or segment a clear occlusal view of the 3D model. So if I don't see the occlusal surfaces of teeth because of no teeth separation, the patient was an intercusp patient while taking the CT scan, it's going to be very, very difficult or almost impossible to obtain this view right there, the 3D view of the CBCT segmentation. Now, let's go back to T separation right there. T separation while taking the CT scan may be done by either placing cotton rolls between arches or by the patient biting on the bite plate on the CBCT scanner. Field of view, limited field of view, and scan cutoff. Now, are these scans sufficient for implant planning? The answer is yes, they are. I mean, bone is visible, adjacent roots are visible, the nerve is visible, but are they sufficient for a surgical guide design? In most cases, the answer is no, they're not. The scan with the cutoff on the right has no cusp tips. So again, segmentation of the 3D view is very, very difficult. And remember, the cusp tips are the reference points required for STL registration. And the quadrant scan, even though it is possible for STL registration, because I see some cusp tips, but as a rule, to eliminate any guesswork and make STL registration a more reliable step, a minimum of 5 teeth are required in any CT scan. And that is why we recommend a full arch scan in surgical guide or in guided cases. Soft tissue separation. Now what we see here are 2 of the recommended methods for soft tissue separation. And I want to thank my dear colleague, Dr. Salma, for the beautiful pictures. 2 methods are either place cotton rolls in the vestibules to separate the cheeks and lips from the gingiva, from the gums, or the blowfish technique, where you ask the patient to blow while keeping their lips sealed, so that air would separate the lips and cheeks from the gums. Now, why is this useful? For STL registration, I mentioned that a minimum of 5 teeth is usually recommended to validate the accuracy of the merge or the registration. Now, if soft tissue is also visible, and an experienced technician or doctor is manually adjusting the STL registration, then 5 teeth is no longer the magic number, and soft tissue may be used for validation. In this lower image, we can see the cotton rolls in the vestibules and how clear the soft tissue is. You see that? And this pink line is following the minor or the mild radiopacity, which is patient's gums. So this is the reason why we recommend soft tissue separation, because it does help in the STL registration. Artifacts. What we see here are 2 of the most common artifacts that we experience or that we see a lot: metal artifacts and motion artifacts. And both make STL registration very unreliable. So how could we deal with them? First, always evaluate your scans, as I mentioned, before dismissing the patient. And if the scans are hazy all over, then probably the patient did move while taking the CT scan. And if so, then consider rescanning the patient. And if the patient or the CT scan has many metal artifacts, and it's too extreme that it's causing scatter and artifacts everywhere, then a dual scan using a suck-down stent is an option. This will be explained in a minute, the dual scan protocol. Another way is, or another thing that may help with artifacts, metal artifacts, is soft tissue separation as well. And if there is an artifact reduction tool in your CBCT machine, consider activating it before taking your scan. So what is dual scan protocol? We've been talking about 2 supported guides and STL registration. Now, what if the patient is totally edentulous? Then your options are either a tissue supported guide or a bone supported guide. A tissue or mucosa supported guide requires the soft tissue be clearly visible and representable in the planning software for a surgical guide design. So a dual scan is the best way to do that. So what's a dual scan? A dual scan protocol is using a scanning appliance, in some cases a well-fitted denture if the patient has one, or a suck-down stent similar to a night guard. And if the patient has less than 5 teeth, because I mentioned 5 teeth is recommended for accurate STL registration. So if the patient has less than 5 teeth, then consider fabricating a scanning appliance, which is a suck-down stent, just like a night guard. Or again, as I mentioned, if the patient has a lot of metalwork in the mouth, then we can also fabricate a suck-down stent before taking a scan. Then attach 4 to 6 Shure markers or fiducial markers, which are basically glass beads with a sticker on them, and place 4 to 6 on the buccal surface of the scanning appliance, just like we see in this picture. And then 4 to 6 on the palatal surface or lingual surface of the denture. Not the fitting surface, but the lingual or palatal polished surface. If you're asking the patients, or if you're using the patient's denture, make sure you realign the denture with a radiolucent liner. Then have the patient wear the denture or scanning appliance and ask them to bite on cotton rolls in the bicuspid molar region to avoid unseating of the denture. Or even use denture adhesive. That's another option. Just make sure it's not radiopaque. Then scan the patient wearing the denture or appliance, and that's one scan. The second scan is never, under any circumstance, scanning the patient again without the denture, because we unfortunately get that a lot. We see 2 scans, 1 scan of the patient without the denture and 1 scan of the patient alone. We don't want that. We want a scan of the patient wearing the denture, and the second scan is scanning the appliance or denture by itself, making sure that the markers did not move from their original position. And that is the dual scan protocol. Now, when these 2 scans are merged together, now not using cusp tips, but using these glass beads or fiducial markers as the reference points, the well-fitted and realigned intaglio surface of the denture now should represent the patient's soft tissue. Makes sense? So again, when these 2 scans are merged together, the fitting surface or intaglio surface of the denture, which is perfectly lined on the patient's soft tissue, will represent the patient's soft tissue, and hence a tissue-supported guide could possibly be fabricated. On the contrary, a bone-supported guide does not require a dual scan and only requires a CT scan of the patient for a surgical guide design, because a CT scan has bone visible and it represents the patient's bridge. So we design a surgical guide on the segmentation of the patient's bone. But I would still recommend a dual scan, even if you're planning a bone-supported guide, not for a surgical guide design, but for treatment planning purposes, where we can easily see the denture teeth and how the emergence of the implants are in relation to the denture teeth. We don't want to plan, or we usually, I was going to say that planning implants without a dual scan for a bone-supported guide, if the implants are emerging too labial from the labial surface of the denture, it's going to make the denture pickup and the prosthesis much more challenging. So a dual scan for treatment planning purposes is always recommended. Now, there are questions that might arise now. I'm going to ask myself some questions, actually. What if the patient is edentulous and does not have a denture nor a suck-down stent? Is it possible to do proper soft tissue separation using the blowfish technique or cotton rolls in vestibules, and then take a good PVS impression of soft tissue instead of a dual scan? Right? As we mentioned, soft tissue separation will make soft tissue visible. So if I do soft tissue separation and take a PVS impression and try to register the STL, is this possible? And the answer is yes, but the STL registration in this specific scenario is done manually and is not as reliable as an accurate dual scan protocol. Another question is, can I use the partial denture for a dual scan? Because we do see this pitfall a lot. A dual scan using the partial denture. Now the answer is no, since the partial denture does not cover the whole arch. So some teeth and some soft tissue that is not covered by the partial denture will not be represented in the CT scan. Another point worth mentioning is that dentures with reinforced metal or barium sulfate will cause artifacts that renders the dual scan registration unreliable. So always use radiolucent relining materials and totally acrylic or fully acrylic dentures or scanning appliances. So, dual scan evaluation. These are the most common mistakes and pitfalls seen in dual scan protocol. Either the denture was not relined and was ill-fitting, or the denture unseated while taking the scan, causing this black shadow between the purple line, which is the denture, and the patient's soft tissue. And this means that the denture fitting surface no longer represents the soft tissue that is needed for an accurate surgical guide design. Another pitfall is that the markers moved and are no longer identical in the two scans. And remember, these are the reference points in the dual scan registration. So if the marker did move between the two scans, they're no longer considered as valid reference points. And as we see on the image on the right, the denture scan had a cutoff, so it does not represent the patient's anterior mucosa. In this case, simply rescan the denture alone if this occurs. Now, after taking the CT scan and the impressions, now it's time to evaluate the patient. And I can easily say that mouth opening and accessibility issues are one of the most common challenges in guided surgery. So the next time you see a patient with less than an average of 48 to 50 millimeters of mouth opening, which is usually more than the width of three fingers, and it's a patient with a missing second molar, then there's a big possibility that accessibility will be challenging. And according to literature, as age increases, mouth opening decreases, and mouth opening, or the average mouth opening is less in females than males. Excuse me. Now, if you do find mouth opening limited, some measures may be taken while treatment planning to tackle this accessibility issue. And I'll give you some hints and tips to try to overcome this challenge later in the session. And I'd like you to meet Bob, my favorite patient. Keratinized soft tissue. Now, there's a general agreement in literature that keratinized soft tissue around implants is essential for aesthetic, functional, and hygiene reasons. So I would recommend that if using a tissue punch, would not leave at least a 2 millimeter collar of keratinized tissue around the implant, consider opening a crestal incision or mini flap to preserve the keratinized soft tissue. Restorative space. Evaluating your restorative space prior to the day of surgery or prior to the day of restoring the implant, and also prior to planning the implant on the planning software is also very, very important. The two most common scenarios are a measly drifted molar and a super erupted tooth. What we see here is a super-erupted tooth. Now, studies show that the minimum vertical height recommended for a screw-retained crown is 5 millimeters and 8 millimeters for a cement-retained crown. Now, this may be resolved by either crowning this opposing tooth, and in such a case, probably you will need endotreatment first before crowning the tooth, or a less ideal solution, but at least it's a solution. It's planting the implant more subcrestal or submerged to increase the vertical height. Either way, it will definitely be more favorable for the dentist, for us and patients, if this is realized before the implant is placed in the patient's jaw. Furthermore, a super-erupted tooth will make accessibility even more challenging. So keep that in mind as well. Now, a mesially drifted tooth is not as big of a problem during the surgery, but I'm sure many of you listening have at least, because it did happen to me personally a couple of times, that a patient comes happy with the implant, but complaining of a food trap and discomfort just distal to the implant, right at the embrasure between the implant and the mesially drifted molar. Now, if this tooth will be crowned, which I would recommend to try to close or decrease the size of the embrasure and avoid the food trap, then I would recommend crowning it before planting the implant. Since the implant's ideal position will be more distal if you do upright this molar. In other words, if this molar is uprighted, then the crown will, or the restorative space will get bigger or larger, then this implant position will be now mesial to the ideal position. This implant should be translated more to the distal to be emerging from the center of the crown. Treatment planning. Now, of course, and it goes without saying that education and expertise in the planning software is key. If you're planning your own cases, and if you're interested in planning your own cases, 3D Diagnostics offers unlimited free training sessions with any purchased Co-Diagnostics software license. Moving on, now since we do a prosthetically, or we always recommend to do a prosthetically driven implant treatment plan, one of the most important steps is designing an accurate virtual crown, bearing in mind the occlusal curves, like the curve of Spee and the curve of Wilson, and the arch curvature, and how the final crown position should be. And if you ask anyone of my dear colleagues and anyone in my team, they will tell you how stubborn and how meticulous I am with virtual crowns, because they have a significant effect on the implant's final position. And my recommendation is that if you have multiple adjacent missing teeth, especially in the aesthetic zone, then either request a physical wax-up from your lab or a digital wax-up from 3GDX, so that the wax-up would be also imported to the planning software for more precise implant positioning in the treatment plan phase. Now, at this stage of treatment planning, the type of guide supports and the guide sleeve type and the guide compatibility, the which kit will be compatible, or the surgical guide will be compatible with which kit, is determined, and also whether a flap is mandatory or not prior to guide seating. From this screenshot, you can see a sleeve not impinging on the soft tissue, which is represented by the reddish orange line here, which means that a flapless surgery is an option. Of course, irrespective of keratinized soft tissue, we're just talking about the distal point of view. And the image on the right shows that the sleeve is impinging on the red line, which means that it's impinging on soft tissue, and as a result, guide will not seat except after reflecting a small mini flap or doing a crescent incision. Fixation pins or stabilization pins. Studies show that fixation pins have a significant effect on guide stability during the surgery. And that's why for tissue and bone supported guides, we recommend a minimum of 4 fixation pins whenever possible. We used to place 3, now we place 4, and sometimes even 5 if possible, because of how important fixation pins are. Even for tooth supported guides, using fixation pins in free end saddle cases where the guide has no distal support have also shown to significantly reduce the error of the guide tilting to the distal while during the osteotomy, which of course, if happened or if occurs, it changes the final implant position, moving the implant apex more to the mesial and the platform more to the distal. And this is one of the cases that we saw with no distal support, and the guide was not stabilized during the surgery, and the implant's apex ended closer than expected to the adjacent root. It wasn't hitting the adjacent root, thankfully, but it was less than 1.5 millimeters away. Verification of treatment plan and surgical kit. Now, working with 3DDX, after we finish a treatment plan, we either schedule an online meeting to discuss the case, and then after the session, we send what we call as the confirmation email, or we send a confirmation email directly without the online meeting, and that is, of course, according to your preference. Now, this confirmation email that we see here contains all information regarding the surgical guide, from finances to clinical notes and concerns, to the type of guide support to which guided kit will be required, and also an attached PDF of screenshots of all the implants, of all the planned implants in all different views is also attached to this confirmation email. Now, it is very important to go over all the notes in this confirmation email, including the agreed upon guide support, which guided kit will be used, whether a crescent incision is mandatory for guide seating or not, do you need bone grafting, do you have the bone graft material and membrane and the implants planned in your inventory or not, are you comfortable with the treatment plan or do you want to rediscuss it? All these questions are definitely better answered at this stage. Now, I will not go into this part in detail, since not many of us design our own surgical guides, but I would recommend that you would use someone with the right expertise to do so, to design your surgical guides. But some of the pitfalls of guide design are not blocking all undercuts on the SDL or fitting surface. And if there are undercuts in the fitting surface, it will obstruct or will not allow guide seating, or having weak areas or thin acrylic support that may cause guide breakage, or surgical guide getting distorted in the 3D printer. Another pitfall or another error that may occur is that sleeves are not glued sufficiently, which may cause the sleeve to pop out. And if this occurs during the surgery, try to place the sleeve back in the surgical guide and try to continue the surgery. Or on the other hand, there may be excess adhesive inside the metal sleeve, which may cause your key or drill not to go all the way inside the sleeve. Now, if this is the situation, and if that ever occurs, and you find your key or drill not fitting in the sleeve, try to use an explorer or a small excavator and remove, first of all, score the sleeve from inside and examine it from the inside, and use your excavator or explorer to remove any excess glue present inside the sleeve. Now, the pre-operative and surgical evaluation, first of all, verification of surgical guide seating. Now, it takes 3DX 3 to 5 working days to deliver the surgical guide. Of course, after you read and approve the confirmation email, and after we have received all of these scans and STLs needed for guide design. And even though 3DX guides pass through many steps of quality control, it is still recommended to open the package, examine the surgical guide, its fit on the printed or sew model sent before the day of surgery. Also, go over the print plan sent with the surgical guide and go through the surgical protocol, clinical notes, and check your inventory for the implants planned. And by the way, these small windows are called inspection windows. This is where you confirm that the guide is perfectly seated. Furthermore, on the day of surgery, or when you see the patient again, make sure the guide fits the patient's mouth before numbing the patient. Now, the reason why I'm saying that is it gives you a chance to consider a couple of options if you did not numb the patient. So what if the guide does not fit the patient's mouth or is rocking? Of course, assuming that the sleeve is not impinging on soft tissue. If it is, then of course, a flap should be open first, and obviously this will be done after numbing the patient. Now, if the guide is designed to go flapless and does not fit the patient's mouth or is rocking in the patient's mouth, then I would say you can consider either taking a new impression and dismissing the patient. But of course, we all know that that's not always possible for all patients. Another option is using articulating paper and placing it in the fitting surface of the surgical guide. Try to seat the guide in the patient's mouth, see where the interferences are, and try to gently relieve any interference in the fitting surface with your straight handpiece, and hopefully this will solve the situation if there are very minor interferences. As I mentioned, go over the print plan and the instruction sheet sent with the surgical guide. Go through the surgical protocol, the clinical notes. In any instruction sheet received by 3DX, you will find clinical notes added in red, starting from the either a crest incision is needed or not, to bone density, to any clinical concerns. Go over all these steps to help you steer clear of any surprises on the day of surgery. And of course, make sure your guided kit has all the drills needed and is, of course, sterile before the surgery. Now to the surgical pitfalls and how to tackle them. As I mentioned, accessibility is one of the major challenges. And if accessibility is challenging and I'm not using the shortest drill in the plan or the shortest drill in the kit, then I would start, or I would try to start the osteotomy with the shortest drill first. So I would use the shortest drill first and then try to use the osteotomy itself to fit in the longer required drills. That's one of the hints if accessibility is challenging. Now, what if I'm using the side opening sleeve? And all right, so this view on the bottom right is a side opening sleeve, which is compatible with some kits. 3DX has a universal kit that is compatible with a side opening sleeve for any case with compromised or with challenging accessibility. But what if I'm using a side opening sleeve and I planned the shortest implant possible? And I am using the shortest drill possible as well, but still mouth opening is very limited. Now, a trick that sometimes helps is trying to assemble the drill and handpiece in the metal key or handle, and the metal key in the surgical guide sleeve outside the patient's mouth, then place them all together in the patient's mouth. So again, remove the guide from the patient's mouth and try to place all the components in the surgical guide, the drill, the handpiece, the key in the surgical guide, and then try to fit all together in the patient's mouth. Sometimes that does help. And sometimes also, and I consider this as a last resort, but if you are not using a kit with a side opening sleeve, you may attempt to create a buccal opening in your surgical guide. So just take out the surgical guide and with one of your drills or a straight handpiece, try to create a buccal channel through the surgical guide. Of course, that may cause a sleeve to pop out or even the guide to break, but again, it's a last resort that sometimes may save the day. Drill fit, surgical guide accuracy. Now it's worth mentioning, and it does make sense that in guided surgery, the accuracy of the fit of the drill in the metal key, and in keyless system, the fit of the drill in the surgical guide affects the amount of wiggle of the components and accordingly affects the accuracy of the drilled osteotomy in relation to the original plan. So I would recommend investing in a well-documented guided surgical kit and using surgical guides with sleeves of correct offsets and dimensions to decrease the microspaces or decrease the offsets and make wiggling less noticeable and your results more accurate. Moreover, it's also worth mentioning that studies show that the longer the drill, the more the apical deviation, there is from the original plan position. So whenever possible, it is recommended to use shorter drills for better accuracy. It is also recommended to avoid putting any lateral pressure on the drills while drilling the osteotomies, and try to be as passive as possible. Now, in addition to better accuracy, also this avoids breaking the drills. Now, especially if you're using a narrow drill like the fixation pin drill, which is only 1.45 millimeters in width. So it does break easily if any lateral pressure is placed on the drill while drilling the osteotomies. And on that note, I would also strongly recommend to have at least one backup fixation pin drill, just in case one breaks during the surgery. Now, whether surgical guide seating requires a crest incision or mini flap, or for fully seating the guide, or you decide on flapping the patient to save keratinized tissue, or perhaps you're using a bone supporting guide or a bone reduction guide, or maybe you're planning to bone graft or augment, so you need to open a flap anyway. In all these situations, always make sure that there's no soft tissue trapped beneath the guide. Now, this may damage or lacerate the soft tissue and will definitely obstruct fully seating of the guide. Now, this may be one of the biggest challenges in guided surgery, and honestly, it does require some surgical skills in some patients to confirm guide seating when a flap is raised. A small helpful trick that helps in reflecting full arch flaps for bone supported and bone reduction guides is suturing the lingual or palatal flap to keep it away or to keep it out of the way as visible in the image on the right. Now, this is one of the crucial steps and one of the most critical pitfalls that a lot of us fall into and could easily be avoided. And no matter how snug the guide is, how accurate the fit is, always, with no exception, stabilize and support the guide while drilling these osteotomies, either yourself or with the help of one of your assistants. And even though it does sound simple to stabilize the guide, but sometimes we get a bit overwhelmed with the keys and the drills and the surgical instruments, and we tend to forget to continuously stabilize the guide. And on the image on the right, this is a case with no distal support. So a fixation pin was added. And to be honest, placing a fixation pin so far posterior, so far distal in the patient's mouth is not always possible. So try your best. If it's not possible, then make sure to support the guide on the anterior aspect to avoid distal tilting of the surgical guide. Irrigation is one of the topics that is very controversial, and very few studies have been conducted testing temperature change during guided surgery. Nevertheless, recent in vitro studies has found that guided surgery generates more heat than conventional freehand surgery. However, it was within the acceptable threshold of maintaining bone vitality. It does not cause thermal osteonecrosis. So even though guided surgery does cause more heat than conventional surgery, but it's not, or it does not exceed 47 degrees Celsius, so it does not cause osteonecrosis. Now, especially in guided surgery, or actually in even in freehand surgery, pumping drilling action when drilling your osteotomies is always recommended. And with surgical guides, whenever possible, use additional external irrigation. So if you have any window or any space between the bone and the surgical guide, try to use some external irrigation. And it's also a good idea to pre-cool your irrigation fluid before the surgery by simply placing it in the fridge for a couple of minutes. Now, taking a PA or a periapical radiograph after the pilot drill is always a great idea. And comparing it with the print plan that was sent with the surgical guide to confirm you are in the correct position is also recommended. And taking another PA after your final drill or after implant placement to confirm implant position and depth will also allow you to evaluate the success of the surgery and dismiss the patient feeling more confident. And I actually would recommend to always take a PA after implant placement, especially in flapless procedures, where you cannot visually confirm the implant's platform position. And that is even more significant when placing the implant freehand, not with the surgical guide, or when using a system that is not fully guided. Now, what is fully guided? Some guided kits include guided implant drivers, where you can place the implant through the guide with depth control. And that of course, is very beneficial, as mentioned before, in flapless procedures or in immediate implant placement in sockets, or in cases where we have low density bone, where the implant can easily migrate or follow the path of least resistance and end up in a different position rather than the pre-drilled osteotomy. And this is an example. The red outline is a post-operative implant, and this blue outline is the planned implant position. The osteotomy was where the blue implant is, but unfortunately, the implant was placed freehand, and there's a buccal defect here, and low density bone. So the implant ended up in the path of least resistance. Now, taking a post-op PA or CT scan, of course, will show this discrepancy. Generally speaking, we always recommend to follow the manufacturer's recommendation when drilling your osteotomies. And even though the doctors in 3DDX would usually let you know the bone quality the implant is planned in, so if the implant is planned in such dense bone, we usually let you know in the confirmation email. And when under drilling, may enhance prime stability. So or if the implant is planned in low density bone, we would recommend or suggest under drilling your osteotomy to enhance prime stability. Nevertheless, your pilot drill, your clinical judgment, and your radiographs are the final judges of the bone quality and of the final implant placement. So if you feel the bone is of very low density, consider under drilling. If the bone is more dense, then consider bone tapping the osteotomy before placing the implant. And if there is thick cortical bone at the crest of the ridge, overlooking or avoiding bone profiling or overlooking countersinking might not allow the implant to go all the way to the final depth required. Now, even though guided surgery has shown its importance and significance in implant surgery, it is important to understand that according to literature, there is a clinically acceptable range of deviation in guided surgery. The International Team for Implantology consensus paper reported that the mean deviations may be approximately 0.9 millimeters at the entry point. Now, for some reason, this image is very exaggerated, but in general, this number 0.9 millimeters is the agreed upon acceptable deviation. And 1.3 millimeters, this looks like 10 millimeters, but the acceptable deviation is 1.3 millimeters. And in depth, it was 0.2 to 0.5 millimeters and 3.5 degrees in angulation, respectively. Therefore, a minimum of 2 millimeters safety distance is usually recommended in treatment planning implants, especially to vital structures like the inferior alveolar nerve. Now, if any unanticipated incident occurs during the surgery, or if you are only recently been introduced to guided surgery and you want to evaluate your results, 3DDX offers to our doctors free post-op evaluation of your scans by superimposition of the post scan or the post-op scan and the pre-planned scans to compare results. Also keep in mind that our custom support is available from 8 a.m. to 8 p.m. Eastern Time. So feel free to give us a call to evaluate the scan even before dismissing the patient if any complication did occur in the surgery. So what is the conclusion here? Now let's sum things up and conclude today's webinar with an important conclusion. But let me ask myself some questions first. Did I or my dental staff take a CBCT following all the guidelines we talked about? And did I check the CBCT myself before dismissing the patient? Did I evaluate the patient's keratinized tissue and decide whether a flap surgery is the way to go or opening a mini flap is better? Did I assess my patient's mouth opening if it's a posterior implant case? Did I measure their start of space vertically and mesodistally? Did I take a PVS impression or intraoral scan or dual scan and inspect its accuracy before dismissing the patient? Did I do a treatment plan and SCI registration and surgical guide design after ample training and expertise, or use the services of a trustworthy and skillful company or digital lab? Did I invest in a fully guided kit? Did I validate and review the surgical protocol prior to the surgery? Did I check guide seating before numbing the patient? And during the surgery, if I have a flap open, did I confirm guide seating with the help of inspection windows and reaffirm no soft tissues obstructing guide seating? Did I or my surgical assistant stabilize the guide throughout the whole procedure? And did I follow the surgical protocol and consider taking a PA after the pilot drill and after implant placement? Well, if I mostly answered yes to the above questions, then I have one more advice for everyone, which is trust the surgical guides. And as Dr. Sabah quoted in his textbook, the learning curve is undeniable, and the clinician with basic surgical skills, including conventional implant dentistry, will be in a better position to address any unforeseen complications. So let's take use of this time that we are stuck at home and keep learning and do not stop the learning curve. I want to thank everyone again for attending this webinar. It truly was a great experience for myself, and I'm open to any questions. So I see my colleagues answered some of the questions. There are no open questions at the moment, but I'm all ears. What CBCT system do you use? Well, I would say that we use, or in 3DX, we accept any CT scan from any scanner. But I would say that we are integrated with Vatek and PlanMecca, where you can directly send us the treatment plan that you did on your planning software on the Vatek and the PlanMecca softwares. Does Implant Direct have their own third party? I'm not quite sure, Dr. Hidayati, if they do have the third party for surgical guide design. Any further questions? Dr. Hidayati, drill stop kit. I know Implant Direct, they do have a fully guided kit, but until this moment, they do not have implant placement control. So they don't have guided implant placement control or guided implant drivers in their kit. What is your experience with in-house milled stents like Sirona? I would say that in 3DX, we 3D print our surgical guides. So I do not, to be honest, I don't have any experience with milled surgical guides. And I would say that 3D printed guides have shown their success in surgeries. In your experience, what is reason number one for guide not seating, I would say an inaccurate impression. So if the impression was not precise or it was an alginate impression, this would be the #1 reason for guide not seating. Can a temporary abutment and crown be fabricated for anterior immediate cases in addition to the guide by 3DDX? I would say yes. We do fabricate temporary abutments, or we do provide temporary abutments, and also can provide CAD/CAM custom-made abutments and provisional crowns for anterior cases. But we usually recommend that you use a fully guided system. And also, if you wish to have an immediate restoration fabricated, then we need you to send us the arch of interest impression, the opposing arch, and also the bite registration. Dr. Alfonso, it's great to have you here. Professori. Now, how accurate is obtaining bone density using CBCT, comparing it to medical CD? I would say, Dr. Alfonso, of course, great question. Now, Hounsfield unit readings was done for medical CTs, and it is much more accurate in CT scans. In CBCT scans, we cannot determine the exact Hounsfield unit reading, but with experience, you are able to know the density of the scan by looking at the marrow spaces or the radiopacity or radiolucency of the bone. Thank you, Dr. Alfonso. In guided implant placement, how to make sure the implant is oriented the same in patient's mouth as in the plan, and how to verify this in the patient's mouth. I would say that taking a PA would only verify the implant position in a 2D view. The only way to confirm the exact implant position is by taking a post-op CT scan. A PA, though, would give you a conclusive answer, and also by comparing the implant position crestally by the print plan provided, and compare both positions to verify if it's in a good position or not. Where do you suggest one go for further implant training? Please go to 3ddx.com. We have some associates in the in continuous education. The Engel Institute is one. The Mish Institute is another. Implant educators as well. There are some courses that I would strongly recommend out there for further implant training. Can you have a temporary hybrid denture also made during guided surgery? Yes, indeed. And please log in next Monday for session 4 by Dr. Todd Engel, where he will be discussing full mouth rehabilitation using temporary hybrid denture and immediate loading of fixed hybrid dentures, fabricated by 3D Diagnostics. A question by Dr. Nicholas Toledo. Hello, any approach to computerized placement of the implant? I would say yes. To place the implant guided, you will need a system or implant system that has a fully guided surgical kit. So I would do some research and choose an implant system that provides a guided surgical kit with guided drivers. Which material do you recommend to stabilize the prosthesis when you scan with the CBCT? I would say that biting on cotton rolls would usually be sufficient, or bite registration. Sometimes some people prefer using bite registration between the dentures while taking the CT scan. Both would work, if I did understand your question right. Also, denture adhesives is an option also that was recommended in some studies. If you're asking about relining the denture, you can use either soft reliners or even hard reliners. We provide Dualine, which is a hard reline material. We also usually recommend a PMMA-based reline material because it's more radiolucent. Now, some PVS or some silicon-based relining materials are also possible. It's a bit radiopaque, but a lot of people use PVS based reline materials, and they usually work just fine. Another question by Dr. Hidayati: is it more advantageous to have guide sleeve closer to the bone or away from the crest, more parallel to the occlusal surface? Great question. Now, literature states that the closer the sleeve is to the bone, and the shorter the drill, the more accurate the results. The longer the arm or the longer the drill and the further away the sleeve from the bone, the larger the deviation is in terms of angulation. Thank you, Dr. Hidayati, for the great questions. Another question is, are you going to avoid palatal or lingual reflection anytime soon? That's a great question by an anonymous attendee. Yes, the answer is yes. We actually did test some of our guides without a palatal flange for bigger cases with bone induction and stackable guides. And they did work very, very good. We did use them in, we did test them in the Ingle Institute with Dr. Todd Ingle in one of his courses. And we are currently working on the development of the guides and quality control of the surgical guides before we could provide them. I have a CBCT that makes model STLs. How does this compare to lab scanners? Should I scan my own? I don't have an intraoral scanner, or send PVS to. That's another great question by Anonymous. Even though it's a possibility to CBCT scan your stone model, but it's never as accurate as an intraoral scan or a scan using a lab scanner of the stone model or impression. So for more reliable and more accurate results, yes, I would definitely either send a PVS to 3DX or the intraoral scan, or send us a stone model poured from a PVS impression. Yes, Dr. Nairi. The question is, if I use Implant Direct Legacy 3, is there a specific fully guided kit with the sleeves you recommend? Implant Direct does have a fully guided kit, but without guided implant placement. So it's a fully guided, or it's guided for only drilling, not implant placement. And so your doctors who plan the guide will tell us if it's flapless or flapped. The answer is yes. In the online meeting or in the confirmation email, and also in the instruction sheet, it's always noted or mentioned if the case would be flapless, or if a flap is mandatory to fully seat the guide. All right, I think I finished all your questions. And if I do find any unanswered question, I will reply to your question via email. Again, I want to thank everyone for attending, and please stay home and stay safe, and hopefully the world will go back to normal very soon. Thank you and have a great one.